That our providers are doing, or I do not know, they are doing a good job, or like at least in the chart, they're good. About 90% of the patients with hypertension, diabetes, more than 90%, they have serum creatinine in the chart. But the detection or ordering for urine protein and albumin is low. And is specifically low if you have only hypertension. If you have diabetes or both hypertension and diabetes, then screening for albuminuria is decent, okay? But if you have only hypertension, then more than 65% of patients do not get albumin detected. And that rate is about 20% if you have hypertension with diabetes or diabetes alone. So the screening for proteinuria in general is low. And then recognition. So in our study, in this our work, we identified that only 43% of the patients who had lab evidence of CKD, they were identified as having CKD. So 57% of the patients who had CKD, they were not identified CKD. And then again, you look at, because CKD can be identified because of the low eGFR or high urine albumin creatinine ratio. So most of the time, the unidentified CKD was when they had higher albuminuria ratio. So the primary care kind of not thinking about albuminuria as a CKD. So that kind of gave us the idea that we need to do more education to the primary care regarding the role of albuminuria. And albuminuria in itself is an independent prognostic factor, as well as mediator of worse outcome. And we have clearly seen patients who have higher albuminuria, they have higher chances of uncontrolled hypertension too. So in terms of factors, like we have univariate analysis as well as like multivariate. So in the univariate analysis, we saw the patients with race other than white. So the minority races, they had lower chances of screening, okay? Then we saw that patients who have comorbidities, so they have heart disease, stroke, tumor, diabetes, hypertension, or both, then they have higher chances of getting screened. Okay, and then patients who have higher number of primary care visit per year, or they have higher number of specialty care visit, and more elective procedures, either radiological or endovascular or cardiac, they had higher chances of getting screening test in the chart. And then patients who are on ACE inhibitor, diuretics, and NSAIDs, they have higher chances of getting screening test. Okay, so these are basically the univariate analysis. But when you do the multivariate, where you are adjusting for all these other factors for each other, comorbidities still stayed positive. Like all these factors kind of like still stood independent of each other, that they were associated with higher screening rate, okay? And so same thing on the recognition side also. One thing which was striking was that, like we saw that races, the minority races had less probability of getting screen tested, but they had higher probability of getting recognized for CKD. If they had CKD, there are higher chances of them having CKD recognized. And it's kind of difficult to analyze from this work that what could be the cause, but our hypothesis, or we postulate the reason are either two, that either providers are familiar that minority races are more prone for CKD development, or these patients have higher advanced stage of CKD. Because in our analysis, we found that people with more advanced CKD, like more stage 4 and 5, and higher albuminuria, they had higher chances of recognition. So it's a possibility that these races, minority races, had higher advanced stage CKD or albuminuria, so they were recognized higher, though they had lower chances of getting screened for CKD, okay? And then another thing which we found for the screening and recognition, that higher number of primary care visit, or high number of specialty care visit, or higher number of elective procedures, then you have higher number probability of having screen tests done. Okay, so you think maybe, oh, primary care are ordering these tests because like there's something wrong. However, that does not translate into higher recognition. So they have more EGFR and serum creatinine and urine albuminuria in their chart, but they are not identified having CKD despite having the lab evidence of CKD. So clearly these tests were ordered just for those procedures, or because patients have comorbidities and they're going to specialty clinic, or they're needing the procedure, and that's why they're getting. But nobody's looking at them, or even if they're looking at it, they're not identifying that patient has CKD. So that was kind of a striking feature. And again, when patients had both diabetes and hypertension, they were more likely to have screening as well as recognition. And that makes sense. When you have diabetes and hypertension, both, you kind of really think about it. And then in terms of medications, so patients who were on ACE and ARB and who were on diuretics, they were more prone for screen and as well as recognition, even in our regression analysis. So that kind of tells that providers who know that patients need diuretics or patients need ACE and ARB, they're aware of the CKD existence. However, one thing which was not very intuitive was the NSAIDs, that we saw that patients who were on NSAIDs, they were less likely to be recognized for CKD. So, which was kind of little counterintuitive. Like usually when NSAIDs is one of the biggest risk, like not biggest, one of the risk factor for kidney injury, right? And then patients who were on NSAIDs, they were less likely to be screened or less likely to be recognized. So we were just wondering about the cause, that it could be that most of the time, what kind of patients need NSAIDs, like who have pain. So the providers were spending more time talking about their pain rather than looking at their other comorbidities and addressing those comorbidities. So their providers' time get consumed by management of the pain, and they have less time, or they do not have time to spend on their other chronic care, because CKD screening and CKD recognition is kind of like part of your routine care. So those kind of get jeopardized. So that was a kind of counterintuitive finding we found. So yeah, these were the factors, and but we clearly saw the patients who were recognized or who were screened, they had lower rate of NSAID. So that's a good thing. Basically, like patients, if they get recognized, they are prescribed NSAID less. So the gist of our work, I would say that yes, screening for CKD, especially the proteinuria, is low. And once they have CKD, the identification or recognition of CKD is on the lower side than what we expect patients to have. And the factors which we came across is that many times, like clearly these tests were ordered not for the screening purposes, but for other purposes. And because a higher number of screening is not translating into high number of recognition. So, and because albuminuria is one of the big reasons, more education of the primary care about the importance of albuminuria for diagnosis as well as prognosis is warranted. So we have to have more work at the primary care level. And once we identify CKD, then we can do more things to kind of take care of the process of care and improve the prognosis of CKD patients. Like, there are a lot of data coming that if you take care of these few things early on CKD, like aggressive control of blood pressure, aggressive control of blood sugars, and these statins and ACE and ARB, then you're going to improve their CKD progression rate and reduce the risk of ESRD. But for that to happen, you have to implement all these interventions early on. And for that, you need to recognize CKD first, right? So that's this whole thing is about, that we need to do a better job of screening and recognizing the CKD for these interventions to implement and improve the prognosis of our patients.